Welcome to everyone. I am very excited for this topic. It's something that I am very passionate about and lecture on extensively, and I'll talk about that at the very end of the presentation in about 45 minutes. But it is a pretty exciting time for aesthetic dentistry, especially minimal prep veneers. That's specifically what I'm going to talk about tonight, but a couple of specific things that revolve around temporization and the patient approving their temporaries, and also picking shades and shapes, because in the world of aesthetic dentistry, boy, I've been doing this for 38 years, and I came from the camps of LBI and Dr. Hornbrook and was well-versed and well-trained in traditional prep veneers. And when minimal prep veneers really got launched by DenMat at about 2005, and they go back to 1982 with the docs in Southern California, doing it with Doc Gibson kind of leading the way. This was his creation. But when minimal prep veneers came out in 2006, I have to admit, most of us were either intrigued or appalled or not sure what to make of it. But I had an 18-year-old daughter about to go to college, and she had some failing composites on enamel. On 7 through 10 and 23 through 26, she was born with defective enamel, and there's no way I could cut down my own child's teeth for prepped veneers at age 18 and then just look at 8 pulps that need a root canal. So I'm like, I can't do this. So I sought out what was available in 2006, and it was DenMat Ceranet veneers. And it has really evolved to what Ivoclar launched with Emax in the early 2000s. So all of these veneers I'm about to show you tonight are all lithium disilicate. Emax is lithium disilicate. So DenMat's lab, they moved 3 years ago to Lompoc from Santa Maria, California, built a new lab. It's like a state-of-the-art lab. It's all digital. They accept all digital scans. I use them extensively because I have 3 arterial generations because we do a lot of Invisalign. So I like the fact that they're a digital lab. I just don't want to work with labs anymore that aren't digital for all the obvious reasons. But you combine this with the Google search engine, and I've seen just an incredible explosion in the last 3 years of doctors looking for offices offering basically Lumineers, because it's the one keyword in the search engine that the prospective patients have figured out means no prep, minimal prep, the least amount of prep. So now if you combine that with, again, the strongest aesthetic porcelain on today's market, which is lithium disilicate, and then take American Academy of Cosmetic Dentistry based smile design and patient approved provisionals. The patient likes their temporaries and they approve their temporaries. And there's a technique I'll show you where I can communicate with the lab what those shapes are. The end result is the patient not only liking their temporaries, but put the final lithium disilicate, I'm going to call them Lumineers because that's the brand name for DenMat is Lumineers, but again, they're lithium disilicate like Emax. The patient is so excited the day of final placement because they've already approved the shapes and the shades, and obviously you get a much better result to get this translucent material in the form of the lithium disilicate porcelain veneers versus the temporaries. So it's really a great feeling as a dentist, 38 years into this, I'm 62, and not to have to hope anymore that the patient's going to like it, because hope is a really bad strategy when it comes to this. I'm no longer over in the corner on one knee hoping the patient's going to like it because they've already approved both the shape and the shades. So let me give you some background on this art process that is DenMat's proprietary process for minimal prep veneers. It's the first protocol, you can see on the slide, specifically designed for minimally invasive smile design dentistry. What it does is it actually establishes a blueprint to get a predictable aesthetic outcome. We're back to not hoping. I just want something that's predictable. I also want something that will eliminate either over prepping or under prepping, guessing and anxiety, and compromised results. Again, back to my 18-year-old daughter, Grace, the last thing I wanted to do was take off any more structure than was necessary to get an aesthetic result. And I remember lecturing with Ed Lowe for a number of years with the AACD, the American Academy of Cosmetic Dentistry, and he coined the phrase responsible aesthetics. And I use this in my dialogue with all of our patients, my existing patients, the new patients seeking us for a consult, because I get 3 to 4 to 5 to 6, sometimes 8 consults a week off of the internet with a proper website and an SEO program that you can get from your web designer. People are looking for offices offering Lumineers. So I talk to them about responsible aesthetics, and here's the definition. I like this definition, and you might want to write this down. Responsible aesthetics, removing the least amount of tooth structure for the desired aesthetic result. So I'm focused on taking the least amount of tooth away to give the patient what they want. And in doing this, I can get a predictable result, I can take on some pretty challenging cases, which means you all, once you take a 1-day or 2-day course and go back to your offices on Monday and start to offer this to your patients, immediately ramp up your bottom line. And again, I know we're all excited to make money. I'm also as interested in giving the patients what they want. They come to my office, they trust me, they know me, they get to meet me if they're a new patient. But I want to get really good results, and I want to take some of these complex cases and make them simple and make it something they can sign up for. Don't get me wrong, every patient signs a consent form, and I go through all the proper protocol and give them all their options. They should have Invisalign, maybe they need something else done. They're not a candidate for veneers at this point, but if the DenMat lab will tell me they are a candidate for this minimal prep art system, and the patient accepts that and signs the consent form, then I'm on board, they're on board, because they really, so many patients, you know this as a dentist, they want a fairly quick outcome. A lot of times it has to do with a major event in their life, or they just don't have the time in their lives to spend a couple years or 18 months on Invisalign, but I always give the patient all their options to make sure they are properly informed. So what's possible with art? Look at a pretty complex case of Brian. I'm just going to overview a couple cases. Obviously, this is just kind of skimming the surface tonight, but Brian came to our office. I'm in Chicago, and he had found out from one of my Milwaukee patients that we were doing this process, this Lumineer process, and he kind of heard about this a little bit through the grapevine. But he looked at my website, saw this thing about the art protocol, so he came down to the office because he'd had 5 consults up in the Milwaukee area. He had crowded teeth, he had misaligned teeth, he had a narrow arch, which is the hardest of the 3 arch types to restore, and he had some occlusal concerns. And again, I'm just skimming the surface here, but take a look at what happens with Brian. When I first looked at him, this was like 2 months into art being launched by DenMat 3 years ago, this past February. One of the dentists up in Milwaukee told Brian that they would recommend orthodontic surgery to split his palate, and he's 42 years old, which sounds like a pretty painful process compared to a 6-year-old where it's cartilage versus an adult where it's bone. But look at what happened here with this process. So here is Brian, and on the right-hand side, you're seeing this protocol that DenMat has developed. They're the only ones in the world that have this protocol. They're polypropylene reduction templates. And they've done a full smile analysis. I'll show some slides coming up to understand what minimally has to be removed off of Brian's teeth to line things up for a great result. So if you look at his clinical picture on the left-hand side, you can see the cuspids look a bit prognathic, the centrals look a bit prognathic. In the old days, I would have extensively prepped these teeth with no real guidelines, just thinking, well, the more I take off, the better it is for the lab because they want some more reduction or more room for the porcelain. When you look at the right-hand side for the facial aspect, that's all the facial reduction that was done on Brian's teeth. I'm going to show you a case about Millie in a moment that explains why prepped gingival margins are not necessary, which means no cutting into the tooth structure, a 0.5 millimeter subgingival, and no packing cord. And then on the lingual, again, looking at Brian's case here, the reason that 7 and 10 are prepped for lithium disilicate Lumineer crowns is if you saw him fully bite down, you would see the incisal, the centric contact point, comes up to where the margin would be on a veneer, and that's a disaster in the making. You have to get past that point. So 7 and 10 became full lithium disilicate crowns, and the rest of them are lithium disilicate Lumineers. So I'm going to refer to them the rest of the night as LD Lumineers. Here's the wax up. So what I didn't understand until DenMat launched art 3 years ago, and I've been doing veneers with most of the top end labs in North America, was they weren't doing a full proper smile analysis and then designing the wax up based on what had to be minimally reduced and then making you a matrix to temporize the cases. Most of the labs just cut back some stone, slap some wax on the model. It looked great on the stone model. It looked decent to okay to atrocious on a lot of my patients' mouths when I went to bond the temporaries to the teeth. So because this is all AACD based and proper smile designs, proper smile analysis, the end result is this, some very nice aesthetic temporaries. Do you see in the upper right hand corner? That was the putty matrix that most labs, again, in North America still use. So I was beta testing this system for them when it first came out 3 years ago, and it went to a clear matrix. And about 1 month later, when Bob suggested to me, "What, you want to try clear matrix?" They polymerized their clear bite, and it went from a dark matrix to a clear, so I could see myself seat that. But this is the buzzword from my 12 years of AACD training, is patient-approved provisionals. So once the patient approves them, and if they don't like totally what they see, I can alter them till they do like them. We'll take an impression, I'll send it to the lab, and they digitally superimpose the shape of the temporaries over the master model to get a predictable result. I mean, that's a pretty awesome result. This is absolutely a life changer. I look at these patients, there's Brian on the left before, and on the right, not the same person. Look at the change in his eyes and his face. I mean, he almost looks like he's been in prison for a while on the left-hand side, and now on the right-hand side, he's happy, he's alive, he can't wait to smile. He sent me a ton of patients from Milwaukee to come down to my Chicago office, but take a look at the bottom screen, and you'll see DenMat at its best with, for the most part, a solid lithium disilicate. You can get up to close to 500 megapascals of flexural strength, which is the strongest veneer system. I'm talking about LD, not zirconia. But they created for me on Brian something called enamel and dentin mamelons to see a variation in the incisal third, a halo effect, some polychromatic gingival warmth, and I finally get the best, strongest porcelain, also looking incredible lifelike. And the end result is taking Brian from the left to the right, which is making a very complex case extremely simple. So the good news for me is I can offer this to Brian because he refused ortho treatment. He said, listen, if I need ortho, nobody's gonna split my palate. I'm just going to live like this the rest of my life. But thanks to DenMat and the smile analysis, I could do what Brian now has on the right. Andrew's case is a simpler one. I want to show you on the left-hand side, he had diastema closure when he was like 18, from 7 through 10. And on the right-hand slide, you see again, solid lithium disilicate. Those are non-prepped gingival margins. There's no prep margin. There's no packing accord. It's a digitally finished and polished veneer that fits into the sulcus about 0.5 millimeter deep, so it doesn't even come close to violating the biologic width. But he has a halo effect. He has incisal translucency. He has gingival warmth. So you can see the right lateral. So 6 and 11, let me go back for a second. 6 and 11 are his natural teeth, and 7, 8, 9, and 10 are porcelain veneers. And I think that almost defies logic that those are actually an artificial material, not his actual natural teeth. His right lateral, his left lateral. And the end result, I'm going to talk about this in a moment, is proper aesthetic design for the teeth, not cosmetic, because cosmetics is making a patient look better, but not considering functionality. Aesthetic design is function first, and the bonus round is that the patient looks really good. Here's Millie. So she came to my office, third-year law student, getting ready to graduate from law school, wants to look, more professional. She doesn't like her diminutive laterals. She said, I look like Bugs Bunny. You can see on the left, that's her pre-op. On the right is her contouring with no shots, no prep gingival margins. And now for the first time, you can see these reduction templates. So look at her left slide there, the picture. That's all I had to take off on the facial, which is very minimal, like a crown and bridge procedure. Let's say you didn't take enough off the occlusal 19. The lab sends you that acrylic template, you snap it over, and you just simply smooth it down until it's even with the template. It's the same thing with these little polypropylene templates, which are really easy to work with. So you simply reduce the tooth till you just score the entire little opening or window about 360 degrees around. And the right-hand side, it shows the incisal cusp tip reduction. So this requires no anesthetic. Again, the right-hand side is her contoured. There's her templates. And here's what really lit my fire when I saw this the first time, is this clear putty matrix. So I loaded up with my material of choice. I seated over the teeth. I can see it seated properly, make sure it is all the way in, let it set for 2 minutes, take it off. And now on the left-hand side is Millie before. The right-hand side are her temporaries. She was so cute. So I have to go back to my mom on the farm where I grew up in Central Illinois. I'll get my mom's opinion, which I thought, that 6 was a little bit too pointy and prognathic. So mom said, yeah, I think you should have it adjusted. But the end result, once we adjusted that, I took an impression of it, I sent it to the lab. And here's Millie's permanent restorations from 5 through 12 for 8 LD Lumineers. And again, a slight halo effect, some incisal translucency with these mamelons the lab will create, and a nice gingival natural warmth that gives the patient something they're really thrilled about and excited. So what is art? It's the next major advancement in evolution of minimally invasive porcelain veneers. You will not find a more productive procedure in dentistry or a better return on investment than doing porcelain veneers. I can go from doing $1,000 an hour for crown and bridge to virtually $2,500 to sometimes $3,000 an hour doing porcelain veneers. DenMat's lab offers something no other lab in the world offers, not even close. And again, my training, which I really enjoy, is AACD based. It's a smile analysis and designed for every single case. Look at Amanda for a moment. So she came to our office. There are 3 categories of art. We train you in all this at the 1-day and 2-day course, but there's a no prep patient because they're no prep. There is a minimal prep, they call it strategic. There's a more involved prep if a patient wants a Hollywood look. But Amanda was a no prep case for the most part because her teeth were all tipped lingually. And you can see in the upper left are her pre-op. The lower left, I simply placed temporaries over her teeth. She had not signed on the dotted line yet. We had not taken any impressions, not doing any contouring the teeth. But this one category, no prep, is quite intriguing because you can show the patient as a final, marketing, selling, educational tool. And when she saw the slide on the right, she signed up in a heartbeat because she could see her worn down dentition was reversed by a material. I use Perfect Temp 10, that's DenMat. I use that a lot. I use Ivoclar's Telio BL3, but DenMat makes a nice range of temporary materials. So I didn't bond this to place. It's just formed over her teeth with a matrix like this that we did on Millie. And then I simply took some pictures so she could take it home with her. But when she saw the end result, she went up to the front desk and signed up with Donna. Let's talk a little bit about proper designing of the smile. And I go into great length with this at the courses, and it's all, again, AACD based. There's so many parameters for how a smile is properly designed. From the upper left-hand corner for gingival display and surface texture coming around counterclockwise to golden proportions, the interdental contacts. I'm over on the lower right-hand corner for the cant of the teeth, the line angles, and the upper right-hand corner has something called central dominance and a proper midline. Again, beauty is in the eye of the beholder. There's no right or wrong. My 3 goals in smile design are to obtain the input from the patient regarding their desires. Let's put it back in the patient's camp. Let's let them tell us what they want instead of us telling them what they think they want, because all of a sudden kind of takes the handcuffs off for me. I don't have to force the patient to like something. They're going to tell me if they like it, and if they don't, I'm going to alter it until they do. And once they say I do like this, then it's like all hands on deck, and it's a major go forward because the patient has approved this. Then I have to transfer these desires to the ceramicist, and I want to provide an ideal aesthetics based on subjective criteria that meet number 1. So again, I'm going to listen, get some photos. We take a LumiSmile on every patient because if I can show them what the potential can look like for them, the success rate for getting patients to sign up based on offering them a LumiSmile is tremendous in my office. And then every patient, I make a set of temporaries for every single patient. I tell them, because of our office and our Lumineer art process and offering responsible aesthetics, that we temporize them, make them a set of temporary Lumineers that they can test drive for a month and improve. And I throw it in that there's no charge for that. Of course, we wouldn't normally charge for temporaries, but it's a nice marketing piece, and it has them see the value of coming to your office because they can test drive the new smile for a month while the lab makes the set of veneers. But obviously, I've got to get them to approve the temporaries and then send an impression to the lab within the first few days after I've temporized them that the patient has approved. Again, we are the architect, the technician's the builder. We have to send them a proper set of plans. But every patient that I'm going to evaluate, I'm going to look at the tooth, the gingiva, because the pink is 50% of the success of the case, not just the white, the pink, the lips, the smile, the face, and the individual. The basics of a great smile revolve around the pink, the tooth, and then also the tooth arrangement in a smile. A gingival zenith is in fact, it's the key component to properly designing a smile, because the pink, the gums have to look natural, and the zenith is the most apical point of the gingival tissue outline. Look at the slide for a second. The yellow is the long axis of the tooth, And the little black T is the proper placement for zenith. So on the centrals and cuspids, the apical height, the highest point of the gum tissue, should be just distal to the long axis, and on the centrals, it's in parallel with that. Look at this slide for a second. You can see with 8 and 9. Do you see how number 8, you can see on the right-hand slide, where on the left is the unhappy? The zenith, the apical height, is actually mesial. That doesn't look like a central. Where you look at number 9 and the zenith is distal to the long axis, that looks like a central incisor. Relative tooth dimensions, talk about central dominance, golden proportion, tooth size. Again, I go into this in great length at our courses. The centrals dominate the smile. It's the key to the smile. The basic premise that I learned from my AACD training is that 8 and 9 need to be identical twins of each other. That's what they're talking about, symmetrical in size and shape. But I like that thought that 8 and 9 should be identical twins of each other. Another good concept, when you look at the proper width to length ratio, should be about 4 to 5. So on the left-hand side, you see that the width is 70% of the length. They almost look like, I don't know, rat or chipmunk or squirrel teeth, versus the middle range there is 80%. And on the right, where the width is 90% of the length, they again look like kind of Bruce Banner or Hulk-like teeth. Also keep in mind, a proper length, and these are guidelines, these are not like steadfast rules, but the proper length for a central incisor for a natural appearance is about 10 to 11 millimeters. You could go with golden proportion, we'll talk about in a moment. If a patient wants golden proportion, that mathematical formulation you can see of the central to the lateral to the cuspid width, it requires more reduction of the teeth. And all my patients sign a consent form. I go through all this in the live course, but they have to understand if they want golden proportion, it's going to require more tooth, and they have to understand what that means and then sign the consent form before we'll proceed. Harmony and balance by the eye, what looks right probably is. This is the whole setup for the patient getting to test drive their temporaries to make sure they like them, and if they want something altered, I'll do that in the first few days till they tell me they do like them. Sometimes it's 2 or 3 5 or 10 minute visits, and then they tell me they like it. We take an impression, send it to the lab, they scan that, and they superimpose those shapes of the temporaries over the master model. I've already sent them a few days earlier. Key considerations in designing the smile. A midline is imperative. You cannot have a canted midline. In my opinion, it's like the worst possible clinical failure is a canted midline. So it needs to be perpendicular to the incisal plane and parallel to the long axis of the face and over the incisal papilla and straight down. How do we prevent midline and canting errors? This is the easiest, slickest system I've seen to date. It's John Coyce's Panodent System Facial Plane Analyzer. All you have to do is Google the word Panodent, and you can order this system. It's about 250 bucks. They send you the kit, the replenishables, which is pretty much just a white biplate and some brown stick adhesive compound points that you warm up in a water bath and put into the patient's mouth. And you can get that rod, that horizontal rod, parallel to the long axis of their face, and that vertical plane, like a fox plane, is perpendicular to the incisal plane. Inexpensive articulator, I like this Stratus 100. I'm talking about, proper case design. The lab has hundreds of these. I have one at my office, so I have a Panodent system, and I have this Stratus 100. So if you want an easy articulator to work with magnetic rings, no need to screw mounting plates on, this is a great articulator that I have at my office. I have one that's fully adjustable, and I can send in the Panodent, and I can mount these cases back at my office for proper case presentation. Tooth criteria, this is really important to talk about the U, the value, and the chroma. The value or the brightness is the most influential. We talk about the chroma, which is the saturation, and then the U or shade or the name of the color. When I talk to the lab, a lot of patients want like really light teeth, right? Americans, North Americans, a lot of people seem to be obsessed with bright white teeth. So if I can control the value or the brightness, I can give them a brighter shade, a lighter shade, but ask the lab for a natural value. It's more translucent and ends up looking quite natural versus these screaming white teeth where I have to tell the patient, please don't tell anybody in the neighborhood that I'm your dentist. Let's talk about temporization for a second. Again, I like this product, DenMat. I use it for my crown and bridge. It's perfect temp 10. What I do is I take an impression of the temporaries once the patient likes, the shape of the temporaries, and the lab will fabricate a digital, they'll actually superimpose those shapes over the teeth themselves, the master model. But initially, with a patient, to get the process started, I'll take some impressions, a bite, some photos. The lab duplicates the models. They do a smile analysis. They wax the case up to ideal situations that the patient has requested, and they make me that clear putty matrix. And I use that matrix, and usually the perfect temp 10, to bond the temporaries to the patient's teeth so they can approve the temporaries. The basic technique: I scrub the teeth clean with chlorhexidine. This is after I've done the contouring for the teeth, taken my final impressions. I've got my face bowl, the Panadint. I've taken my bite. I'm ready to temporize the case. So I'll clean the teeth with chlorhexidine. You always want to use that, whether you're doing a filling, a crown, anything. You want to scrub the teeth clean with chlorhexidine to get the bacterial biofilm off of there. I'll polish the teeth with this porcelain laminate polishing paste. I'll rinse and dry. I etch the teeth. And you can see the etching pattern. I'm just spot etching because I want to be able to pop these off with a scaler or a hemostat 4 weeks later, not have to cut them off. So that's the pattern of the etching. I'll use a micro brush and just put a central dot in the midfacial and one across the incisal. Again, just a picture of that. Rinse and dry for 20 seconds. I like DenMat's Etch and Seal because it has aluminum oxalate, which actually etches the dentin without waking it up. If there is dentin, and I etch a lot of dentin. So I'm going to cover only the etched pattern with one coat of Tenure A and B and a micro sponge and blow it towards the incisal, not the gingival. Put a coat of Tenure S on, blow it towards the incisal, cure for 3 seconds, and then I'm going to do this. I'm going to load up that clear putty matrix. I tip it on its axis towards the facial. I load up the facial half of each tooth, and I seed it. Like you see the picture on the left. These are Kim's teeth. You can see on the right. That's her temporaries. I think that's a really nice looking set of temporaries. That's BL2, DenMat's Perfect Temp 10 BL2, bonded over her contour teeth. The reason you see the much shorter gum height not being corrected on number 8 versus 9, you'll see her smile in a moment. She doesn't have a high lip line. So if they don't show it, I don't have to contour the gum tissue. There's their burr system. So I like this F diamond for contouring on the facial aspect and opening up the embrasure slightly from the facial so they can clean the temporaries with a soft pick because they can't floss for the 4 weeks till the lab makes the veneers. I like that E diamond on the lingual aspect. Let me show you that for a moment. So there's that F football shaped diamond. You can see me just creating a little more of an opening, the embrasure, the gingival embrasure between 7 and 8 there. I can also roll the facial margin in because these are no prep gingival margins. It kind of causes us to get outside our boxes because we're used to prepping a gingival margin, but we don't prep any type of margin when we do direct composite veneers. We kind of roll the composite in at the facial aspect. It's the same thing with this process. And when DenMat can digitally create a rolled, smooth gingival margin, I can bond it into sulcus. To me, that's much healthier than cutting a margin sub G, a lot of times encroaching upon the biologic width and causing some chronic inflammation. There's that E football shaped diamond on the lingual to clean up that porcelain. Then I'm showing, I picked certain shades. The BL2, DenMat's Perfect Temp 10 BL2 comes out to be at an OM3. That's the shade she picked. That's the B2 3D Master Shade Guide. Kim wanted OM3. There's her temporaries on the right and left. You can see her before, her trial smile. She approved the shape. She hated her rounded teeth. She's like, nobody I see in nursing school, she's 21, has rounded teeth. And then on the right-hand side, to give her more natural smile, she loved it. She approved it, and the lab made the permanent LD Lumineers to that exact same shape and shade, but it was porcelain. The end step, because I have this oxygen inhibited layer, is to clean that off with a polishing disc. And then I like to use this product, the Dentsply's Pogo Points, so I can polish the surface to get that inhibited layer off of there, and then take Gloss and Seal and put a coating on, and that what gives the teeth that polished look that you saw for Kim and Millie's teeth. The old matrix was that dark blue thing. I don't ever want to use that again, and I won't, because I run all my veneer cases through the DenMat lab because they're the only ones that have art. And the power of a trial smile. Patient likes the temporaries, they approve them, I take an impression. They're excited the day of placement because I keep telling them you're going to get an even better look with this translucent lithium disilicate Lumineer material. Again, the pink is 50% of the success of any smile makeover. You have to always keep that in mind. This is not turning into a laser lecture, but look at the three things that I highlighted in red. The advantages of using, say, an 808 nanometer soft tissue diode laser, no recession after I contour the gum tissue, faster healing, less anesthesia required. I could use a tack topic, whatever you like to use on the gum tissue. A laser will cut, coagulate, cauterize, and sterilize. This is the cutting edge of today's dentistry for proper design of the gum tissue and creating zeniths that look natural, like the slide I showed you before. So look at Ashley for a moment. That's not a good look for her, right? She's got hyperplastic gum tissue. You see how much gum tissue is showing in her smile. Again, I'm always probing the sulcus depth and maintaining proper sulcus depth for not violating the biologic width. So we do some bone sounding, we'll do some probing, make sure everything is okay, and then I will trim back the gum tissue to a level that allows her to still have a proper biological width. But this is her before, lateral views. There's actually immediately after I trimmed her. This one laser, it used to be Xyla, and DenMat bought Xyla a number of years ago. So Mike Miyazaki from LVI and also DenMat turned me on to this laser, and it's fantastic. There's no cords. It's 2 watts is the maximum power source that I need for any of these procedures. But look at what I did with Ashley's gum tissue to make it symmetrical, because again, pink is 50% of the success of the case. Proper zenith height, I uncovered the laterals more, and the end result, above is before, below is contoured. Immediately after contouring, you can take an immediate impression, because this laser, 808 nanometers, will only affect 3 cell layers, where a electrosurge will affect 1,000 cell layers, so I don't get recession post-op. Again, post-procedure for the laser, you can see her healed. Those are her LD Lumineers on, and look at the end result. That's not the same person. This woman's entire life was changed. She sent me 11 consults, 7 ended up getting Lumineers because of the end result. And a lot of the success has to be based on the gum tissue, so you have to evaluate that for every single patient. One thing, all my training with the LVI and Hornbrook, it was all this idealized smile design and trying to get golden proportions and make it look perfectly symmetrical. Well, it turns out not only is natural not always perfect, but it can be beautiful, it can be youthful, and if you explain to the patient all their options, like, you know what, Dr. Peter, I'll take natural versus Hollywood, because you've explained to me it's much less invasive and I'd like the least invasive process, I'm back to telling the patients that we always practice responsible aesthetics. So again, you could talk about having a natural smile where we're going to enhance the patient's natural tooth form and their own personality, versus this Hollywood perfect smile, which would be golden proportion and maybe LVI smile designs. I'm not knocking LVI, by the way. I practiced that for many years. I'm looking at the landscape of what patients want in today's society. I'm also looking at the technology exists. And because of the Google search engine, my ability to offer this evolution, the best part of this evolution of minimal prep veneers, that's why we're doing 75 to 100 veneers a month now, because patients want this and I am trained and offer it. Not perfect, but still beautiful. Natural smiles are designed for patients who like their tooth shape and form. They don't want to look radically different. At the same time, they want to make enhancements, like maybe straighten the teeth a little bit more, get that permanent whitening process. So the possibilities would be patients with worn or chipped edges, which is a lot of people, closed spaces, a lot of people with diastemas, correct the alignment, brighten and lighten, and correct functional issues. Question to the patient, and this is what I ask them, do you want to look like you but younger or prettier, or younger with a brighter, prettier smile? And when I open up that door, they're like, yeah, I do. But if they tell me, no, I want this Hollywood smile, maybe they bring me pictures, what they have in mind, then we talk about the reality of what it is to do a Hollywood smile versus a natural smile. Look at her for a moment. She's got asymmetrical laterals. Look at 7 and 10. 7 is somewhat rounded on the incisal and 10's flatter, but she's got a beautiful smile. So not perfect, but still beautiful. Let's cover Hollywood for a second. I think we all know what that means with golden proportions. And you can see the gentleman on the left, a natural smile, the woman on the right, a perfectly symmetrical golden proportion smile, but you have to properly inform the patient and get them to sign the consent that it is going to require more tooth reduction. Again, imperfect symmetry on the left, natural will require less tooth reduction, and the lab will help you decide this. The lab helps you to tell you what category it fits into based on filling out the lab script, interviewing the patient, sending the proper pictures, so you won't have to figure this out. The lab is incredibly customer-centric now. And the newer folks that took over come from Arrowhead, and they obviously really know the veneer business. The head of education, Jen Archer, and the CEO, Dave Casper, these folks are the real deal. So they have taken the lab and the company to a place I've not seen it before. So as a customer, I'm excited because we do a lot of veneers per month. Again, perfect symmetry, Hollywood on the right, may require more tooth reduction. I could show them a style guide. You could download something like this off the internet. It shows you just have to type in those words and you'll see the template for that if the patient doesn't know, or I'll tell them, bring some pictures of what you have in mind. Everyone's not a Hollywood star. Many patients just want to look and feel better about themselves. Look at Jeff for a second. So this is a patient we did nothing to except take some impressions and pictures and send it to the lab. He is basically a no prep case for 7, 8, 9, and 10. We did some whitening on 6 and 11 before we get to the final reduction or minimal reduction impression, but we never prepped anything. They sent me back a putty matrix based on a wax up. They even draped the matrix, the temporaries, over his gum line. So all we did was put the temporaries over his teeth. We hadn't done anything. We're not etching anything. We're not bonding anything into place. But we did a chairside mock-up on him and talk about selling the case to the one person sitting in the back of the room who wanted his teeth fixed was his wife, Cheryl. Said, I can't look at you more, honey. I love you dearly, but you look terrible, so let's do something. And she signed him up immediately when she saw that result. So again, the trial smile ensures the case acceptance by your patient. Here's Shannon. This is a good example. So Shannon comes to our office. You can see her teeth badly worn and chipped on the left-hand side. The right-hand side are her final LD Lumineers cemented to place. You can see a little bit of gingival irritation. We had to pack some cord to keep the gums from bleeding because her hygiene wasn't as good as we'd hoped it would be. But this is what happened with Shannon. On the left is her before. On the right is a smile design from the lab based on her handing me a bunch of pictures the first day she came of Kate Hudson. She wanted to look like Kate Hudson, who had some centrally dominant 8 and 9, shorter laterals. So we put the temporaries in. I adjusted them a couple times. I took an impression of it. Again, I even put some shade tabs in because Shannon kept telling me, I want OM1. I want the lightest, brightest teeth that you can give me. And I understood she wanted light teeth, and she showed me the OM1 shade tab, or I showed it to her against her temporaries, because the temporaries came out about OM2. So on the right-hand side, you can see her teeth are actually a little bit brighter than OM1, what she loved, but that's a natural value. That's not a high value that makes them look like screaming white teeth. So communicate with the lab. If your patient tells you, I want screaming white, blank white teeth, I will give it to them, but it's under great duress that I used to, comply with that. Obviously, it's their time, their money, but I try to explain to them, educate them. I can give you that OM1 shade, but give you a natural value and have it look really good versus just screaming white. And I don't think anybody looks good with screaming white, high value teeth, not in that OM1 range. Again, Shannon gets what she asked for. There's the OM1 shade tab. Look closely for a moment at the incisal edge. That's that variation and customization of the incisal flow to make them look like natural teeth. It's got a little halo effect, and here's her OM1 end result. In summary, these patient-approved provisionals, ask your patient to bring examples of what they want. Use a style guide if you need to. That LVI guide you can download off the internet. Interview them on what they want, Hollywood versus natural. Once the trial smile is bonded to place, I'll give them a few days. I call them every day, see how they're doing. If they like it, I've already taken an impression before they left the first day. If not, have them come back, alter it, and then I will take an impression and send that to the lab. One more case. Here's Anthony, a barista smile. He wanted to look like Loki. Loki from the Avengers is this English actor, Tom Hiddleston. So I brought him pictures of Tom Hiddleston and said, make me look like Loki. It was kind of a fun day because I was like, okay, I'll be Thor, you'll be Loki. You'll have this great smile at the end, because I'm a huge Marvel fan from the 60s and having comic books back in the 60s. But the best part about this was he gave me a specific guide. So look at this. Those are his temporaries. Those aren't his final veneers. That is his BL2 perfect temporaries bonded to place, and he was just blown away by the temporaries. I like when they say, I'll just keep the temps, and obviously that's not going to happen because they're connected, they're going to break down over time and they'll stain. But the end result was to give him something that he was just ecstatic with, because the landscape is so ripe right now for patients seeking your offices once you're fully trained with this. There's a couple of different courses. I really like the course on the left. Dr. Terry Alani in Houston, Texas is the Snap-on doctor on planet Earth. She does a full presentation on things you never thought Snap-on Smile could work for. Provisionalization, no more flippers when you have an implant case, but making a change in people's lives when they can't afford a $10,000 makeover, they can afford a $2,000 Snap-on Smile. So she and I team up to give a great one-day course to get you fully trained for these art veneers, and also the latest information technology for Snap-on Smile. Or I also give a full 2-day course, which goes even more into depth with the art. You can see that on the right.